Hello, everyone. Thank you for those that tuned in. Hello to everyone who may be watching later on the YouTube channel. Happy Memorial Day weekend, which we don't have in Australia, but obviously it's a very patriotic holiday. So I wish all the Americans the best. Now, next slide is our disclaimer. Next slide, please. So today, Orlando, Florida. We've had a session there last year, which was very successful. And so after ASCRS being last month, we had a break from Journal Club, and we thought having 2 months off was too much. And so again, thanks for those that are tuning in today, given the holidays. I tried to find an interesting fact about the host city. And so I looked up where one can see alligators in Orlando. And according to the World Wide Web, you can see them in Lake Monroe, St. John River, Lake Kissimmee. And then it also says you can see them on walking trails and most other bodies of water. So it seems like an interesting place to live.
Doesn't sound good.
I can get Chris Aquina, one of the fellows at Advent Health, to now say a few words about the institution and the city and his experience, please.
Sure. You're not far from it. I mean, basically the rule of thumb is assume there's alligators in all the lakes, just to stay safe. But Orlando's a great city. I've been here a year now. I'm currently a fellow at Advent Health. Obviously, when you think of Orlando, everyone thinks of Disney World, so I figured I'd include photos other than Disney World. One interesting things is, despite Cape Canaveral being about 60 miles away, on clear nights, most of the time you're able to see the actual rocket launchers, which are more frequent now with SpaceX. So as you can see on the photo over to the left, there's a nice picture from the soccer stadium showing one of the rocket launches. And then over to the right is a picture of downtown Orlando. And then the main campus in Orlando is just to the right in the photograph. You can't see it in the photo though. And then Advent Health has been expanding. It's quite a few campuses now. This is a picture of the main campus near downtown Orlando. The colorectal surgery fellowship currently has 5 fellows, 3 ACGME, and then 2 MIS fellows. We all rotate in the same rotations. And the faculty has been growing. It's currently at 12 attendings.
Great. Thank you very much for that. Next slide, please. I'll introduce Professor Nelson later, but very grateful to have him. And part of the Journal Club will be a segment about sort of analyses where I'm really looking forward to asking him some questions. Next slide, please. And before we start presenting the first article, we're going to have a bit of a poll. And so I guess particularly given the first paper is a systematic review, my question to the audience would be, when would you consider performing a meta-analysis? And we'll leave the poll up for a bit, and then we'll address it later on. Stephen will give us the results. So thanks for that. Next slide, please. So the first paper we've got is actually a paper published by the team at Advent Health. The title is Cytoreduction Surgery and Hypothermic Intraperitoneal Chemotherapy for Colorectal Peritoneal Metastases, a Systematic Review. And if I can get Chris to kindly present it, and then we'll start the discussion. Thank you, Chris.
So just a little background on peritoneal metastasis from colorectal cancer. It's quite common. About 10 to 15% of patients present with peritoneal disease at the time of their initial colorectal cancer diagnosis, and then an additional 20 to 50% will develop peritoneal disease after curative intent surgery. As you probably know, peritoneal metastasis is associated with a poor prognosis and is the second leading cause of death in colorectal cancer. It's also associated with the worst survival compared to other metastatic sites, which you can see in the graph on the right. These are patients with isolated distant metastasis, and the black line represents patients with peritoneal disease, and they have worse survival compared to those with liver and lung metastasis. For patients who are untreated, the median overall survival is about 6 to 8 months. For those who undergo systemic therapy alone, the median survival is about 16 months. For patients who are candidates for cytoreductive surgery and can undergo complete cytoreduction, some patients can be cured. Most recently, the recent Peritoneal 7 trial showed that a median overall survival of 41 months. However, the basis for this study that we're going to go over, there's been a lack of consensus on patient selection and treatment protocols. So systematic review is performed on recent studies. So as I alluded to, systematic review is performed. Inclusion criteria included randomized controlled trials, and then observational studies, which were prospective or retrospective in design between 2004 and 2019. Patients had to have diagnosis of colorectal peritoneal metastasis, treatment with cytoreductive surgery and HIPEC, and then the studies had to have reported at least 2 of the 4 outcomes, which I'll mention in a second. Studies were excluded if there was no specific information on the study population, diagnosis, treatment, and then any case series with less than 20 patients were excluded. In terms of intervention, all the studies included cytoreductive surgery and HIPEC. As there's no comparison group, there's no control. And then the 4 outcome measures that were looked at were overall survival, disease-free survival, morbidity, and mortality. Next slide. So moving on to the results. Overall, there was 26 studies that were included. There was 1 clinical trial, 11 prospective studies, and 14 retrospective studies. Most of the studies were from Europe. Only 4 of the studies were from the United States. And then quite a large proportion of the studies were published more recently between 2016 and 2019. Overall, there was quite a bit of heterogeneity with respect to the HIPEC techniques. 50% of the studies used the closed technique, 44% used the open Coliseum technique. The duration of HIPEC varied from anywhere from 30 minutes to 100 minutes. And then the chemotherapy agents for the HIPEC varied between mitomycin C alone, oxaliplatin alone, and then a combination of chemotherapy agents. Similarly, there was wide variation in outcomes across the studies. In terms of obtaining a CC0, meaning that there was no visible disease after cytoreduction. Across the studies, that was anywhere from 7.8% to all of the patients achieving a CC0. And then a CC2, which is any nodules between 2.5 millimeters and 2.5 centimeters, for which the patients don't really derive any benefit from cytoreduction. That was as high as 36% across studies. In terms of median overall survival, it varied anywhere from a year to over 5 years. The median disease-free survival ranged from anywhere from 9 months to 36 months. Morbidity ranged from anywhere from 11% to 56%. And then postoperative mortality ranged from anywhere from 0% to 34%. So quite a bit of variation across these studies. Next slide. So in conclusion, like I said, there's been substantial heterogeneity across studies in terms of HIPEC protocols and outcomes. Obviously, this discussion would be remiss without at least mentioning the recent Peritoneal 7 trial, which was not included in the systematic review because it only includes studies that were published through 2019. But a brief overview, the inclusion criteria for the study was patients with the peritoneal carcinomatosis index of 25 or less, and they had to have undergone a complete cytoreduction, which was considered residual disease less than 1 millimeter. The comparison groups were cytoreductive surgery and HIPEC plus systemic therapy versus cytoreductive surgery alone without HIPEC and systemic therapy. And then the HIPEC included oxaliplatin for a duration of 30 minutes. The main finding was that there was no overall survival benefit. However, the median overall survival was quite high, which is a lot higher than most previous studies at around 41 months. So this study showed that long-term survival is possible with complete cytoreduction and systemic therapy. However, the role of HIPEC remains unclear. As the study used oxaliplatin at 30 minutes, which is not the standard across most institutions, at least in the United States, I think the ideal randomized controlled trial would be comparing cytoreductive surgery alone versus cytoreductive surgery with HIPEC, but using mitomycin C for 90 to 100 minutes, obviously in patients where complete cytoreduction is feasible.
Thank you very much for that. That's a great summary. For me, one of the sort of elephants in the room when it comes to many colorectal cancer interventions is the appropriate radiological staging, because it's very hard to characterize who needs a peritonectomy, particularly in an interval or not. Chris, how does your hospital or colorectal sort of tumor board flow when it comes to these sort of borderline cases, and who do you refer to peritonectomy, and is it a special unit or is it part of what you do?
Sure. So just a little background. I had done a surgical oncology fellowship at Ohio State prior to my colorectal fellowship at Advent Health. We currently don't have a peritoneal surface malignancy program at Advent Health. The plan is to start one in the near future. But in terms of patient selection, typically what we would do for patients with peritoneal disease is to do a diagnostic laparoscopy before, to get a sense of what the peritoneal carcinomatosis index is. For appendiceal cancer and low-grade appendiceal mucinous neoplasm, especially for Lamin, the prognosis is quite good, so the PCI doesn't matter as much. If you can get a CC0 or CC1, most of those patients do well even with very high PCIs. For colorectal cancer, it's a little bit different. The patients have, the prognosis is worse. So some studies will give PCI cutoffs, but there are some studies that suggest as long as you can get complete cytoreduction, either a CC0 or CC1, meaning residual disease less than 2.5 millimeters, that the patients will benefit from cytoreductive surgery. So typically the pre-op work would be a diagnostic laparoscopy to get a sense of the disease burden. Some institutions will do MRI, like a MRI with the peritoneum protocol. But in my experience, it's I don't know, we didn't really do it much at Ohio State because we found that the diagnostic laparoscopy seemed to give a better, more accurate at estimating the PCI.
Thank you. If I can see Justin Kelly and Jesse Wright are there, and I think they're from your institution, if I'm not mistaken. Perhaps if they're available to answer, I've got a clinical scenario. It's a patient that I've operated on about a year ago. A lady, BMI of about 30, presented with a large bowel obstruction due to a ascending colon cancer. And so I took her to theatre and did a right hemicolectomy and noted that she did have some peritoneal disease, no mucin, but given that she was acutely obstructed, I resected and joined her up, and she did relatively well. No, by that I mean no post-operative complications, recovered, started on adjuvant chemotherapy. But I don't now know, like, when do you refer these patients? When do you do a diagnostic laparoscopy, or when do you refer someone to do a diagnostic laparoscopy? Have you had such scenarios, and what would you do?
Well, as Dr. Akwana referenced, the program was just getting started here at Advent. In the past, the most important thing that we've been told and been stressing on surgeons in the OR is to go ahead and calculate a PCI as best you can while you're in the operating room for whatever you're going to resect. So in the setting of an obstructing lesion or any other need for urgent or timely resection, I think that proceeding in that manner is appropriate. But we've gone several tumor boards where other people have sent their patients our way without obtaining a PCI. So then proceeding with a diagnostic laparoscopy up front would be very reasonable, as Chris alluded to.
Okay, thank you. I've got a couple of questions, perhaps from the methodology point of view, and maybe I'll be fortunate to get Dr. Nelson to weigh in. Now, the first question I have is, in the study, they mentioned that there's some geographical heterogeneity in terms of where the studies are from. How much weight would you put on that? Does that matter? And is it specific to what you're investigating in the study? Do you ever look at that, Australia versus UK versus America, or is it all about the same?
About the same, I would say. And you've got to read what they published and look more at the quality specifically in what they're presenting. But right, I don't think it's a kind of, to judge anything beyond that would be a bit rocky.
Okay, and the other question in a sort of a similar manner, in the methodology here, they mentioned that 14 studies were prospective and 12 studies were retrospective. Can we group them together? And also, should you weigh them so that a prospective one would, arguably be a better quality document than a retrospective one?
Once you leave the world of randomized trials, you're in muddy water no matter what. Certainly, the prospective studies are going to have data collected with some thought and some planning. In retrospective, you got to go with what they got. So it's bound to be weaker. But beyond that, as I say, I think that there's not a heck of a lot of difference between those two, and a huge difference between either one of them and randomized studies.
Okay. And so,
Vlad, if I may interrupt, one of the problems with the Pradesh study was that was cited before was that it was so it was such a wide range of PCI scores, and if you just did a subset analysis of the patients that had 11 to 15, they actually had a very good outcome. And you have to remember, it was widely criticized because they had such a short perfusion time of only 30 minutes, and they were using oxaliplatin. So, I mean, given it was a randomized study, but there were a lot of problems with it. But if you just do a subset analysis and look at those data, there actually were fairly good results.
On the one hand, there's a lot of weaknesses in randomized trials. On the other, subgroup analyses in randomized trials are supposed to be forbidden because it destroys your randomization.
okay.
Now, I wonder, Rick, what do you think about doing systematic reviews when there is that much heterogeneity among the subjects? I mean, here there are different techniques of doing the perfusion. There's people who are doing Coliseum. There are people who are doing closed techniques. They're using different drugs, different durations. I mean, can you even compare something like that?
Yeah, well, yeah, in a text you can. I mean, you can certainly do a systematic review of it, right?
Yeah.
The question is, when do you cross the bridge into meta-analysis?
Mm-hmm.
And that depends on the degree of heterogeneity.
Mm-hmm.
If you're really comparing things that are simply not comparable, then you shouldn't attempt a meta-analysis.
Which they're not, which they're not doing. But I mean,
Yeah,
I think it's very
exactly.
important also to do quality assessments of studies.
I mean, these studies like this at best can generate hypotheses to lead to the appropriate randomized studies.
Mm-hmm.
As far as the quality of evidence beyond that, it's awfully thin ice. There's just too many variables. But I think the subgroup analyses, when they're justifiable, even in randomized trials, which you're never supposed to do, is to generate hypotheses. And that's as far as you should go with them. I mean, speaking strictly as far as process rather than what good is all this data anyway, but yeah, these data.
That's quite interesting. I personally find that the Coliseum technique, purely by its name, is far more appealing than the closed technique. So surely that's a bias in itself.
No, because OSHA just asked her. I mean, you're basically having open vapors of chemotherapy medication floating around. So no, I don't think anybody likes that.
One last question I have about this study. In the discussion, I think there was it was touched upon sort of the quality of life impacts of doing peritonectomies and HIPEC. And personally, having had myself, I find it difficult to talk to patients in terms of, what are the significance of an ileus? Is the ileus worse? I also haven't seen in any papers if there's a functional bowel sort of problem with a delay, like is there peristaltic effects of having chemotherapy down the line? Does anyone know anything about that, or any even anecdotal opinions in terms of the outcomes for patients from a quality of life perspective? Anyone from the audience has a particular view on it, and I think it'll be an interesting sort of addition to a proper consent and discussion. Okay, well, thanks for this, Chris. I'm sorry I'm going to subject you to another presentation. So let's proceed to the next paper, please. So the second paper is called Risk Factors for Peritoneal Recurrence in Stage 2 and 3 Colon Cancer. It's brought to us from a team from Japan. Please start when you're ready.
Sure. Actually, just quickly going back to the prior discussion, talking about important pieces of information pre-operative. The other thing that's very important, which I sort of alluded to but didn't say, is the histology. So that really dictates the prognosis as well. So the patients with colorectal cancer, they have signet ring cell, those patients have poor prognosis. Unless they have a very low PCI, they probably shouldn't be undergoing cytoreductive surgery. Whereas, like I said before, appendiceal tend to do better. Lamin, vast majority of those patients are candidates, well differentiated. Appendiceal adenocarcinoma, they tend to do well as well. And then once you get into colorectal cancer and moderately poorly differentiated appendiceal, then you should start considering neoadjuvant chemotherapy before the cytoreduction to see the disease response or stability of the disease. So I just wanted to mention that as well.
Yeah,
we can move on to the second page.
Yeah, no, that was a good point, actually, because I have it written down for the last paper. This will be the last thing, that the comment from the authors was that only a few of the reported studies reported on tumor biology, including histological findings and specific biomarkers. So I take your point. I think it's very important, and it is explored sufficiently.
So the second paper, the basis for that study is there had been little information on risk factors for peritoneal recurrence following potentially curative colon cancer resection. Prior studies have been limited to just population-based observational studies. So this study sought to identify risk factors using pooled data from 3 randomized controlled trials from Japan. Next slide. Like I said, it was a pooled retrospective analysis of randomized controlled trial data. A brief overview of the trials. The first 2 trials with the JFMC trials 7 and 15, enrollment occurred quite a long time ago, 1986 to 1990. Inclusion criteria included patients with Dukes B or C colorectal cancer, age less than 75, and then no severe postoperative complications. All of those patients received adjuvant capecitabine for 1 year. And then the other trial was the JFMC trial 33. That enrollment was more recent, between 2005 and 2007. Inclusion criteria include patients with T4N0 or stage 3 colorectal cancer, age between 20 and 75, good performance status, PCOG of 0 to 1, and no prior treatment. And all those patients underwent adjuvant chemotherapy with Tegafur and leucovorin within 6 weeks of surgery for either 6 or 18 months of duration. And then from those studies, further inclusion criteria were patients with stage 2 or 3 colon cancer that had undergone at least a D2 lymphadenectomy. Just a reminder of what the different classifications of lymphadenectomies. You can see the diagram on the right. D1 is just basically just removing the lymph nodes. Like it's not a standard oncologic resection, just removing the lymph nodes close to the colon. A D2 is your conventional oncologic resection, which is removing the lymph nodes along the artery. And a D3 is taking the lymph nodes along the origin of the artery, which would be considered your complete mesocolon excision. And then D4 is basically excising periaortic nodes, very central nodes. And then for exclusion criteria, they exclude patients with rectal cancer and distant metastatic disease. There's no comparison group. And then for outcomes, they looked at peritoneal recurrence-free survival as well as overall survival. Next slide. So overall, there was a little over 3,700 patients included in the study. Interestingly, only 2.3% of patients developed peritoneal disease. And then 66% of those patients had peritoneal carcinomatosis only without evidence of any other distant metastatic disease. Just to highlight some of the tables and figures, table 3 shows factors associated with the main outcome measure of peritoneal free survival. As you can see, age less than 60 was associated with the higher risk. And then T4 compared to T3, lymph node positivity, and then D2 versus D3 was a higher risk of developing peritoneal carcinomatosis. Figure 2 then shows the overall survival comparing patients with non-peritoneal recurrence and those with peritoneal recurrence. And as we alluded to earlier, peritoneal recurrence associated with a worse survival compared to this recurrence at other distant sites. Next slide. So overall, the study, I think, showed that basically, following appropriate oncologic resection of stage 2 or 3 colon cancer, metachronous peritoneal disease is quite rare, 2.4%. As we showed in the prior table, risk factors include age less than 60, T4 tumors, nodal positivity, and then D2 versus the D3 lymphadenectomy. In the discussion, the author did give some recommendations. One of them was that they recommended D3 lymphadenectomy if there was for any tumors with node positivity. And they also mentioned doing a planned second look with possible cytoreductive surgery and HIPEC for T4 tumors. That recommendation was, I think it was before the 2 trials, which I'll talk about in a second. The first point, I think the real thing is, does the benefit outweigh the potential morbidity of a D3 lymphadenectomy? In Japan, they do it much more commonly. I think in the study, it was 2/3 of the patients underwent a D3 lymphadenectomy and only 1/3 underwent D2. In the US, where it's not done as commonly, I would think the risk of postoperative complications would be quite higher just with the less experience among surgeons. And then the other points is that for stage 1 through 3 patients, they calculated a number needed to treat of 200. For node positive patients, the number needed to treat dropped to 60. However, as you know, unless you see enlarged lymph nodes on the scan, it's hard to predict which patients have node positivity preoperatively. And then, as I was saying before, there's 2 trials that have been done since this publication, and they show that there's no evidence for second look surgery with HIPEC for high-risk patients based on these studies. The first one was the Profellowship Prodige 15 trial. They included patients with colorectal cancer, either resected localized synchronous peritoneal metastasis, ovarian mets, or perforated primary tumor. All the patients received adjuvant chemotherapy for 6 months, and then they had a negative CT scan that didn't show any evidence of peritoneal disease on surveillance. The 2 arms are surveillance versus second look laparotomy plus HIPEC, which was either oxaliplatin or mitomycin C for 30 minutes. What they found was that there's no difference in disease-free survival or overall survival between the 2 arms. And then the second trial was the Colopec trial. That trial included patients with either clinical or pathologic T4 tumors or perforated tumor without distant metastasis. The 2 arms included adjuvant systemic therapy alone versus prophylactic HIPEC with oxaliplatin for 30 minutes plus adjuvant systemic therapy. And similar to the prior trial, there was no difference with the peritoneal metastasis-free survival at 18 months between the two arms.
Thank you very much. That's a great summary. Thanks for adding the extra bits of the discussion. One of the questions I have, perhaps if Jesse Wright is still available, maybe he can shed light on that from a local perspective. The authors sort of talk about how in their study they had no perforated cancers, which I think is remarkable. But and they also said that that the recurrence rate was low. One of the things that I don't sometimes nut out is the difference between local recurrence and persistence. And so how would you differentiate if there is persistent disease at a local site versus an actual peritoneal recurrence? And would you treat patients differently based on that?
I think it's a fantastic question. I too struggle with this, and I'm in my junior years of this process as well. So I would defer this question to some of the more senior folks on the call, but I've struggled with the same issues, and with the hindsight of what you know post-operatively, re-reviewing imaging and seeing what's imaging clues may have been there in the past, trending your biomarkers certainly is part of this. But no, tumor biology is seriously at play here, but I would have to defer to those who've seen more of these to be able to kind of discern those differences.
Yeah, it's one of those. I guess there's I don't know. I go back to the limitations of radiology sometimes, and it is a challenge. In the paper, the authors say that their results support a planned second look, which is interesting. The planned second look is a lot more difficult to do if someone's had a laparotomy before compared to a laparoscopy. So is it a fait accompli if someone's had a laparotomy, then the second look is a laparotomy? Can you say that you can do a laparoscopy in a limited field and gauge on that? Or Chris, from your sort of surgical oncology experience, if you do have to restage people from a PCI perspective, what have you seen?
I mean, I think if there's any concern for a recurrence, especially, then you attempt to do a diagnostic laparoscopy again to assess whether there is in fact a peritoneal recurrence. And then if there is, to get an estimate of the disease burden. I mean, there is, especially when you start, sometimes patients who undergo cytoreductive surgery and HIPAC, obviously the recurrence rates can be quite high. It's definitely challenging to try to do a repeat diagnostic laparoscopy in a patient who's undergone a laparotomy with the HIPAC. There's usually a lot of adhesions. We basically just, it ends up being a limited diagnostic laparoscopy. I mean, a lot of times the diagnostic laparoscopy, it's really just to determine whether the patient is a candidate to even undergo the laparotomy and exploration. A lot of times you can't see everywhere and get a full sense of the PCI. So, I mean, some of the areas that are not going to be resectables if they have disease, around the stomach or the porta, or if there's a lot of disease in the mesentery, those are patients that are not likely going to be candidates for cytoreductive surgery and HIPAC. So kind of more as a rule out to say, yeah, this patient's not going to benefit and we're not going to do the laparotomy.
Okay. Well, thank you. I find that this is quite a challenging topic. The last question, I think, Justin Kelly's raised his hand. So can we give him the microphone and then we'll proceed to the poll?
Hi, Vlad. Thanks for including me. Just a couple of salient points from Chris's talk. I think that CT preoperatively is a poor correlate for pathological lymphadenopathy. And no matter what type of CT or imaging that you do, I don't think it correlates very well for definitive pathological lymphadenopathy. The second point is that extrapolating data from a population that are completely different really to the rest of the world is a difficult sell in performing, you know, extended lymphadenectomy, D3 and beyond. Our patients tend to be different structurally, anatomically, and adiposity from those where a lot of those, that fantastic surgery is done more commonly. To answer your question about a perforation and local recurrence versus residual peritoneal disease, I think a lot of that would depend on what your initial operation was and how extensive it was, and whether you got R0, whether you got an R0 pattern on it or not. I have not been involved in many second look laparotomies, and like Chris said, and perhaps going back to the question that you asked about the first paper, Vlad, about the patient with the obstructing right colon requiring emergency operation, that they would, in our jurisdiction, perhaps they would typically get adjuvant treatment and then reassessed after a period of 4 to 6 months. And then again, that they would be reassessed whether, like Chris had spoken about, either a diagnostic laparoscopy or as much imaging as you can to see whether they would benefit from a subsequent HIPEC procedure. So they were just the two snippets that I picked up on.
Thank you. Thanks. That's very useful. Let's move on to the poll now, which is our discussion about, you know, when to perform a meta-analysis. Stephen.
Yeah. So your first option, the ill-mannered, I'm not stupid option, I don't think anybody took that. So there are people, I think, that I guess are generally believers in some utility of meta-analysis, but certainly the main answer was after a systemic review was analyzed. That you had kind of hinted at the one above that. The second place answer is, you know, a study with a homogeneous population, that systematic review is probably more appropriate, or sorry, heterogeneous is more appropriate, and you know, homogeneous population might be better for a meta-analysis.
Okay, thank you. And this is a segue into introducing Dr. Nelson. Margaret, if we can bring that slide up. So Dr. Nelson grew up in Chicago. He studied ancient Greek, which I found amazing. And then he subsequently got his MD from the University of Chicago, and as well as that, traveled to undertake some genetic research in London before completing his surgical and colorectal training. He's been a staff surgeon at the University of Illinois for 33 years, and also a surgeon at the Northern General Hospital in Sheffield University for 9 years. He's been an ASCARS representative and served in the different facets of the Cochrane Colorectal Cancer Group for 18 years. And I think in the last 8 years, he's been involved in the School of Public Health in University of Illinois as an adjunct professor of epidemiology. And according to the World Wide Web, is also a keen alto horn player. So now that we've introduced him, I'd really like to make use of your knowledge and also find out your role at the moment at DC&R as one of 2 statistical editors. What does that role mean, and what do you do?
Let me make the disclaimer first, and that is I am not a statistician. I've never been a statistician. I've never taken a course in statistics or an exam and gotten a degree. I have been thought to be a statistician by some of my colleagues in colorectal, because I argued about certain methodological issues in clinical trials that cause all sorts of problems. And I think that's the big difference, is that there's statisticians where I work at UI School of Public Health, and they speak a completely different language than I do. They read different journals than I do. I'm in the epidemiology side. And we work hard on methodology, both in clinical trials and in observational epi too. But with at some frequency going to statisticians like Dr. Banerjee when we really need some help. But having said that, I remember I was in the Board of Education in my kids' school in the early 80s. And I must have had something about statistics go on in my head, because I tried to get school teachers there to teach statistics in grade school, thinking all it is arithmetic. It's not rocket science by a long shot, but everybody in the adult population was scared to death of it. You'd see it in newspapers and people would get all nervous, etc. And real statistics is scary, but I don't deal there. I deal in methodology, and that's a different bird. So that's a long answer to your question. I think that for the, I can't remember seeing any really difficult statistical stuff in the clinical trials I review. It's all pretty straightforward, and the errors are made with things like subgroup analyses and people in randomized trials. I mean, anything that disturbs the randomization is poison to a clinical trial. And there's a lot of things that do. The biggest one is loss of data. People get lost to follow up and the data disappears. And there's many things methodologically where it happens a lot. And I don't know if you've seen something called the modified intention to treat in any of the studies you've read. They're everywhere. New England Journal, Lancet published them. And it's a way to trash the randomization, and the journals accept it. And I just don't understand it. Long answer to your question.
We're going to, thank you. We're going to put the next slide up, which is actually from your paper. And we've got the reference from the paper for the audience and recording later, about sort of the meta-analysis that you can trust. Margaret, can you flip the next slide? Yes. So how to find a meta-analysis you can trust is the reference of the paper. Can you please expand on that paper and rate?
This is from a very short paper I wrote for Techniques in Coloproctology, in which I found, as a reviewer, places where people tripped up seriously, just doing something as simple as a meta-analysis. The software exists, so everybody has a go at it. One of the things to be particularly wary of, this is another aspect that's serious in meta-analysis. And Cochrane was very energetic in trying to pursue it and get it disseminated. And that is the risk of bias. Where do biases can work their way into a meta-analysis? Just randomizing it first, then allocation concealment, and then who observes the final thing are all places where biases come in. And in their way of graphically showing it in a Cochrane review were the sort of traffic lights you see here, which is green is good, low risk of bias. Yellow is awful because it means we didn't know. The author didn't talk about it. My feeling is if an author doesn't write something, he didn't do it, period. And so many people will do things like this saying, oh, he probably used a good randomization technique. No, if he didn't write it, he didn't do it, I promise you. And then the black means a very high risk of that, of bias in this study. This was a study using probiotics to decrease the risk of wound infection in colorectal surgery, along with an intravenous antibiotic. So I took all the studies that this guy included in his meta-analysis, and the next slide shows how I would have graded those studies instead of the way he did. And you see a lot more red because there are things that the authors simply didn't describe in their text. And that's methodology. It's not statistics. If they said, if they didn't say anything about blinding, that means it didn't happen. If they didn't say anything about allocation concealment, that means it didn't happen. And these all introduce massive, especially when you start doing something like, well, that's a different story, mixing non-randomized trials with randomized trials in a single meta-analysis. It really sinks the boat. So I think that what I learned at Cochrane, and it took years to hammer it into my head, was methodology in clinical trials. And to the degree that fairly simple statistics plays a place in it.
Thank you, Dr. Nelson. Margaret, can I have the next slide with the the next question I have is, and you've sent me some references as homework, the second one on the line. What is your take of the common errors, or more to the point for the audience here, what are the ones that you would prefer to warn us about to avoid making?
Well, first of all, could I speak a little bit about these publications themselves, because they're all, especially the first two, absolutely terrific. Subverting randomization. It's only 3 pages long, and it's about how critical allocation concealment is. The people doing the study can't learn what's going to happen to the patient if it's at all possible. With surgery, that gets real touchy at times. But anyway, the second one it's a longer paper, 8 pages, but it's 20 paragraphs, all very short, listing where you really make big errors. And I don't know why this guy published it in the Croatian Medical Journal. When I saw the CMJ, I thought it was Canadian Medical Journal, until I looked at the name. I hope it's not difficult for people to get it, because this is the best thing I could recommend for anybody that reviews this. With the YouTube things later, it's great reading, and if you do that, you'll be ready for anything. I promise you.
It's open access on PubMed. Sorry to interrupt. That's how I got it. So it's certainly not hard. I'm just surprised that you read the Croatian Medical Journal.
And he says everything much better than I can. Much, much better. The thing that got me this funny job with DC&R was this letter to the editor of DC&R at the bottom, where a fellow was talking about cost benefit for Triloxan, this antibiotic infused sutures for sewing up wounds. And he said he proved that it was a great money saver. But when you do cost benefit analysis, the first thing you have to look at is benefit. And so when I read this paper, I went to see where he obtained his concept of benefit. And he did 3 meta-analyses in 3 consecutive years with major errors in each one, like mixing non-randomized trials with randomized trials, while not looking at attrition and how many people dropped off so that it couldn't be assessed at the end. Those are all fatal errors in a meta-analysis, and simple, all summarized in the number 3. How many are there? I should count. All I say is get the paper by Tom Lang and read it. He'll tell you all of them. And I'll try to tell most of them in the one after that. I think breaking a randomization is the biggest. That's the biggest. And it's so easy to do, either by loss of, as I say, dropouts, or bad randomization, or bad concealment.
Thank you, Dr. Nelson. And another question I have, you've mentioned about the author doing 3 meta-analyses in consequent years. Now, perhaps from your experience in Cochrane, when would you decide that it's time to repeat a meta-analysis? How does that process work?
Cochrane had a policy when I first joined them that every analysis had to be updated every 2 years. We looked for new publications, and if there were no new publications in the field, the update was simply 2 sentences at the top saying no new data. But I'm in the midst now of my 5th updating of antibiotic treatment of Clostridium difficile, because there's some new antibiotics out there and they need to be reviewed. We have 7 new studies since the last one I did, which was not 2 years ago, it was 5 years ago, 2017. So I think repeating a meta-analysis can be very helpful when there's new data, when there are new data. But this guy did them all wrong. It's funny because I'm going to his university in 2 weeks to celebrate my wife's 50th medical school reunion, University of Newcastle upon Tyne, which is where he published this from. Maybe I'll get a chance to find him and shake his hand. I doubt it.
Just be safe. Now, the next question I have is, say, if a young doctor wants to do a systematic review and the topic is reasonable and there's not much published on the topic, how would you recommend determining when to stop at a systematic review, when to proceed to a meta-analysis? At what point does this happen? And when does a statistician need to be formally consulted, if ever?
Yeah, you know, a statistician is not really what you need for this type of literature. It's really somebody that has an experience having done a systematic review and meta-analysis, so they're clued in on the methodology. That's really it. And this became a rule in Cochrane. It had a lot of new rules over the last 10 years, and some of them got pretty offensive. But you know, you couldn't do there without a senior, experienced person being on the authorship. You know, I think that somebody else I feel has become a critical member of the crew. And I used to think, oh no, I just do a search myself in PubMed, is a medical librarian. They're worth their weight in gold. They can find things so much more efficiently than I can and so much more thoroughly. So if you've got a medical library near you and you want to do a systematic review, meet the librarian, chat them up, buy them a beer, and see if they'll help you get through this stuff. I think this is the biggest revolution in medicine. When I was in my training in junior faculty, what you wanted was somebody's opinion when you asked them to come by and talk to you. And he generating his opinion, he got the literature out that agreed with his opinion. And with the advent of Cochrane, that quagmire burst open to evidence, and evidence that it was objectively obtained, which is what systematic review is. Before you have any ideas or any preferences, you do your literature search first. And it's got to be a good search. And then get the data and see what you can do. The first paper you presented today, there's no way you're ever going to do a meta-analysis from that paper. As the author said, it's just too heterogeneous a group. They spread too far. But some heterogeneity is a good thing because it makes it more applicable to the general population. If you have some variation in gender or age or whatever, you know, therapies, then those can actually strengthen a meta-analysis rather than destroy it, that degree of heterogeneity. But the strength of the evidence, the certainty of the evidence is our goal with every meta-analysis, not the quality. Quality is kind of a dead term there, but how safe do you feel that what you've learned in this meta-analysis would be applicable to one of your patients?
Thank you. My last question, unless there's anyone else in the audience, is this notion of a network meta-analysis.
Oh man. I love them, but they still are a bit over my head. You know, this is one of the few areas where it's okay to mix non-randomized trials with randomized trials. Is in a network meta-analysis. And I haven't quite gotten that state. There's my favorite author in statistics is a guy named Stuart Baker. Write down the name. He's a statistician at NCI. And he writes short little papers that surgeons can read, and they're brilliant. And one of the ones which is my favorite paper, is if A is bigger than B and B is bigger than C, does that mean A is bigger than C? You'd all say, of course, right? No, a statistician would say absolutely not. Statistically, it doesn't work. And that is the essence of network meta-analysis, is something called transitivity. And I get a lot of meta-analyses networks to review. And if they don't talk a lot about transitivity and how they dealt with it in their paper, and the consistency in the paper too, and that's where the non-randomized trials come in. If they just do the software and don't ever get around to talking about that, then I reject the paper. It's dead in the water. Transitivity and consistency are critical factors in that work. But I'm still working my way through it.
Well, thank you very much for answering these questions. I find this topic very intimidating. And now that you said that A and C is like, it's even more intimidating. I don't even know how to use the alphabet. But anyway, thanks everyone for their time, particularly on this Memorial Day weekend. Our next meeting will be next month, and it's we're going to focus on the K-pouch, and this is going to be in New York and Columbia University. So again, thanks everyone, and have a lovely rest of your evening.
Well, thank you for the invitation. Good night.